Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on face and orbit. It will include the gross anatomy part. The objectives of these presentations are the general idea, describing the general idea of face and detail of the gross anatomy of the face, defining the orbit, its boundaries and contents, and at every stage we'll try to correlate clinically. Face provides the identity. See, looking at the face, we can identify a person, who that person is. Is the basic shape of the face is determined by underlying bone as well as the fatty tissue, the color of the skin, and the aging change in the skin. All this together maintain the shape of the face, and all are playing an important role in giving the identity of a particular face. This is a face. You see the red line is drawn at the level of the chin, proceeding on either side along the inferior border of the mandible. This is the inferior limit of the face. The upper limit is the hairline or hair margin. Between this area is the face, and it laterally extends up to the tragus. But in many cases, it's very difficult to identify the hair line of the head because of the presence of different size of baldness. So that's why many a time face is considered as this eyebrow level. So in that case, the face extends from chin to eyebrow, tragus to tragus, and inferior border of the mandible to the as the inferior limit of the face. In that case, this part is considered as forehead. Forehead sometimes considered as a part of the skull or part of the face. Considering the gross anatomy of the face, it has some peculiarities. Like the face has the skin and superficial fascia, but is not having any deep fascia. The muscles take origin from either bones or from the fascia and inserted into the skin, and these muscles control the expression of the face. That's why it is known as muscles of facial expression. So all the muscles together are grouped as the muscles of facial expressions. The skin of the face has many sweat glands and sebaceous gland. It lies on the connective tissue which contains the muscles. This skin has some tension line or wrinkle lines. These are clinically very important. This is because of the presence of thick interlacing collagen fiber with the elastic fiber in the dermis, and this collagen predominates, and the pattern produces a characteristic line in the face, as I have shown in the diagram. The wrinkle lines or tensile lines are also known as cleavage or Langer's line. This is present all over the body and with the different directions and in different planes. That is the clinical significance. If the surgeon apply the incision along the line, the healing will be better, and reverse will happen if the incision is made perpendicular to the line. So the surgeon should have a clear idea how to identify the wrinkle lines. Let us explain how this happens. This the figure indicates this on the left side. This is the direction of the collagen fibers. So this is along this long axis. So if we make an incision along the direction of the collagen fiber, means along the direction of the wrinkle line, then you see the retraction or separation of the margin of the incision will be minimum. So there will be less gap between the margins, so healing will be better. But if reverse the actually incision is made perpendicular to the collagen fiber, the retraction of the margins, incision margins will be more because of the tension of the fibers away from the incision side. So this will require very closely opposed in stitching, and otherwise there will be a large scar marking. You can see, this person, when she was young, the skin of the face was very smooth, but with the age you have seen that some changes are happening in the skin. There are wrinkles appearing in the skin, and that increases with the age. This is known as sag or wrinkles of the skin. With the age, this wrinkles increases. Why? Because of the elastic fibers in the dermis gradually deteriorates. So the elasticity of the skin reduced, and ultimately with the age the total elasticity will be lost, leading to thick wrinkles in the skin. We know that the muscles of the face are known as muscles of facial expression. They remain in the underlying loose connective tissue. So the gap between the muscles are filled with the loose connective tissue, and these muscles originate from bone or subcutaneous tissue and finally inserts into the skin. So this is responsible for different expressions of the face because of the change in wrinkles produced in the skin, or changing the uh, size of the orifice of the face, like eye orifice, oral orifice, nasal orifice. So this can be changed with the action of the muscles. So these expressions are together controlled by all the muscles of the facial expressions. There are a number of muscles of facial expressions. Above, you can see the labeling from above downward. The muscle above is known as frontal belly of occipitofrontalis. Below that, you can see on the right side the temporalis. Below the in the midline, close to the midline, corrugator superciliary. Below that, you can see the labeling on the left side, orbicularis oculi. In this way, you can follow all the names and can see the position of muscles. How do they work? They can work individually or in group. Let us see some examples. This person is having some wrinkles that is vertically in the midline above the nose, means between the eyebrow. This is done by the corrugator superciliary. Look at this, the forehead, and you can see that both the eyebrow are elevated. This is done by the frontal belly of the occipitofrontalis muscle together with the corrugator superciliary. This is doing the increasing the wrinkles. You can look at the left eye. It is tightly closed, so it is done by the orbicularis oculi muscle. Look at the mouth. It is tightly closed, but it is in position, so it is done by the orbicularis oris. It is not elevated or pushed downward. Look at the upper lip. The left side of the upper lip is elevated and other parts is okay. So this is done by the levator labii superioris and levator anguli oris of the left side. Look at this person. The cheek is tightly depressed, so this is done by the vaccinator. The oral mouth is, the lips are tightly together, and this is done by the orbicularis oris, and also it is elevated up, so it is done by the levator labii superioris and levator anguli oris together. In this way, these facial muscles of the facial expression works individually or can work together. All these muscles are supplied by the facial nerve. Look at this person. I'm giving a few seconds time and have note. What is your finding? What are your findings? Is there any expression? There is no wrinkle. Eyes are looking straight. Actually, it looks like a expressionless face. Let us look opposite side. Now, what is the expression? There are so many wrinkles. The person is anxious. The same persons having a different expression on the left side and different on the right side. Let us look up. The expression is, there is some expression in the forehead, but it's not that much anxious looking at you. But when you look at the below, it looks like the person is very anxious. So there is change in expression on either side and in different places. Look at together. The face is pulled on the left side. The angle of the mouth is pulled on the left side. Why? Because the muscles of the facial expression on the right sides are paralyzed. You see, the facial nerve of the right side is having some way, it is lesion is there, so this is paralyzed. That's why the muscles of the left side is unopposed and they are pulling the angle of the mouth towards the left, more towards the left. There is no balance. You see, even there is no balance in the nose position. So this is the feature when there is lesion of the facial nerve because of the motor paralysis. Face is supplied by the facial artery. You see, this is the external carotid artery, which is the branch of the common carotid artery. From the anterior part of the external carotid artery, we know that there is, from below upward, there is superior thyroid artery, lingual artery, and then arises the facial artery. So it arises from the anterior aspects of, this is the facial artery of the external carotid artery, just above the origin of the lingual artery. This lies in the origin lies in the carotid triangle, and if we follow the hyoid bone, this one is the hyoid bone, then posteriorly we'll get the cornu of the hyoid bone, and this will be a very good guide to the facial artery. Just above this tip of this cornu, this facial artery runs anteriorly and superiorly. This is the facial artery. You can see this is entering into the face, hooking round the inferior border of the mandible, just anterior inferior to the masseter muscle. So it is curving round the base of the mandible, means inferior border of the mandible, just anterior to the masseter muscle. Then it follows a very tortuous course. You can see this is the masseter, and it runs upward towards the angle of the mouth, following a very tortuous course, ascend further by the side of the nose, then it goes up to the medial side of the eye. So throughout the length it is very tortuous and give many branches to the structures of the face. This is the area where we can feel the pulse. This is anterior border of the masseter, close to the base of the mandible. At this area, facial artery is exposed to the skin, and it lies in the subcutaneous tissue of the face, means superficial fascia of the face. Throughout the length, the facial artery follows a very tortuous course. What is the benefit of this tortuous course? Let us discuss. The benefit out of the tortuous course includes that this can adapt the movement of the mandible and the pharynx during deglutition, and mandible, lip, and cheek during talking or shouting or like that. It contains more blood because of the tortuosity. The length increases, so it contains more blood, and that can meet the demand of the total demand of the structures of the face. So these two are the most common benefits we get out of its tortuosity. Veins of the face starts from the small veins of the forehead. They unite together to form supratrochlear vein in the medial side, and this is the supraorbital vein on the lateral side. Both these vein descends downward, fuse together to form the angular vein. You can see this angular vein with the side of medial side of the eye. Then and you can see the anterior part. This is the supratrochlear and supraorbital vein unites together to form the angular vein. This descends downward to form the facial vein, and facial vein along with the facial artery descends downward. From the lateral side of the face, the vein drains posteriorly to the superficial temporal vein, and this superficial temporal vein descends downward, unites together behind the neck of the mandible to form the retromandibular vein. This retromandibular vein within the parotid gland divides into posterior division and anterior division. The anterior division, you can see, unites with the facial vein and finally opens into the internal jugular vein as a common vein. So this is the venous drainage of the face. The venous drainage has some clinical significance. The face vein doesn't have all the veins are not having valves. So pressure within the vein controls its direction. Sometimes venous blood flows back because of the change of pressure. In that case, the intracranial communication of the facial veins are important. Within the skull, in the center of the skull, a sinus is there, venous sinus, that is cavernous sinus, and this cavernous sinus is having communication within the cranial cavity with various sinuses. So this facial vein is connected to this cavernous sinus by some connecting vein. Superiorly, this connecting vein connects the angular vein with the cavernous sinus. Below the orbit, the facial vein has connection with the pterygoid venous plexus, and pterygoid venous plexus has communicating vein that connects this plexus with the ophthalmic vein, and that ophthalmic vein takes it to the cavernous sinus. So in all direction, the facial vein has multiple ways of connecting veins to be connected with the cavernous sinus, which is situated at the central part of the cranial fossa and has connection with other sinuses. So disease material can go and spread within the cranial cavity from the face, and that's why this area, including the upper lip and lower part of the nose, is considered deep to that is the part of the palate is considered as the danger area of the face, from where the infection can easily spread intracranially, means can go to the cavernous sinus and spread all over the cranial fossa, cranial cavity. Lymphatic drainage. Face has only two groups of lymph nodes and drains limited lymphatics, and these are the buccal group of lymph node and parotid group of lymph nodes. This is the submandibular group and this is the submental group. So this submandibular group of lymph node, this carries most of the lymph from the face, cheek, nose, upper lip, gum and tongue. The submental group of lymph node carries lymph from the tip of the tongue, lower lip and chin. The buccal group and the parotid group accept lymph from the scalp, auricle, eyelids and cheeks, and the buccal group receives lymph from the forehead as well as anterior part of the face. This buccal group and parotid group has the lymphatic veins that carries their lymph and finally opens into the jugulodigastric node present below the angle of the mandible. Innervation. The sensory supply of the face is from the three divisions of the trigeminal nerve, and this supplies most of the area of the face except over the angle of the mandible and the skin over the lower part of the parotid gland as shown in the figure, and it is visible on the figure on the right side uh, by blue color. This is the ophthalmic division shown by the red color. This is the maxillary division shown by the yellow color. This is the mandibular division supply area shown by the a bit pinkish color, and the blue color is showing the cervical 2 and the yellow is showing the area supplied by the cervical 3rd ventral rami. So these two units are present in the greater auricular nerve that supplies this area. Let us discuss about the gross anatomy of orbit. Is a pyramidal cavity present in the facial skeleton of the skull. This is having a base that faces anteriorly and it is open. The base has a margin that is known as orbital margin. It is formed superiorly by the frontal bone which hangs laterally and medially. The lateral border is that of the orbital margin is mainly formed by the zygomatic bone, and zygomatic bones proceed laterally in the lower border of the orbital margin. This lower border is also formed by the maxilla. The maxilla is also frontal process of the maxilla for forming the medial part of the orbital margin mainly, but partly in the superior part is formed by the frontal bone. The apex directed posteriorly, and this is the apex. This is indicated by a foramen which is known as optic canal. This is present in the lesser wing of the sphenoid bone. This is the orbit. Different bones are shown by different colors so that you can understand the composition or components of the wall, various walls. Like the roof is formed by the frontal bone. This is known as orbital plate of the frontal bone. The lateral wall is formed anteriorly by the zygomatic bone and behind by the sphenoid bone. The floor is formed mainly by the maxilla and also anteriorly by the zygomatic bone. The medial wall from anterior to posterior, it is formed by the frontal process of the maxilla. This is lacrimal bone. This one is the ethmoid bone. Orbit is a pyramidal structure. The base is open, and this is the base. This is the base which is stained, and the red color is indicating the orbital margin. So with this opening, the anterior orbital opening, It is connected with the structures of the face. Let me show other openings by the label and its connection. So this one, this rounded one, is the optic canal, and through this it is connected, orbit is connected to the medial cranial fossa, and this one is the superior orbital fissure. Through this orbit is connected to the middle cranial fossa, and this one is the inferior orbital fissure. Through this orbit is connected to pterygopalatine fossa. In the medial wall, in the anterior part, there is an opening that leads into a canal. This is the nasolacrimal canal. You can see in the figure on the left side, the lacrimal sac proceeds as the nasolacrimal duct through this opening into the canal. What are the contents of the orbit? Let us explain serially. So first, the largest structure, actually this orbit is for the eyeball. So the eyeball occupies the central part of the orbit, and it is separated from the bony wall, and it is maintained in position by the surrounding structures we'll now discuss. So this eyeball is surrounded first by the extraocular muscles. Four of them are rectus and two of them are oblique muscles. You can see these are the extraocular muscles of the eyeball, and it is the important content of the orbit. Blood vessels. This one is the ophthalmic artery, branch of internal carotid artery. So this ophthalmic artery gets inside the orbit and repeatedly branch. So ophthalmic artery and its branches are important content of the orbit. This is the branch of internal carotid artery. The veins are the tributaries of ophthalmic vein. Let me label it. This is the ophthalmic vein, and the veins of the orbit drains into the ophthalmic vein. So all the tributaries are the content of the orbit. Nerves. I will label the nerves one by one. This one is the frontal nerve. This one is the nasociliary nerve, and this is the lacrimal nerve. So all these three are the branches of ophthalmic division of trigeminal nerve, which is the fifth cranial nerve. This one is the trochlear nerve, and it is the fourth cranial nerve. We need to dissect a bit to see the optic nerve. You see the tendon is reflected from the superior part, and you can see the optic nerve is present in the orbit. Another photograph is showing the oculomotor nerve. This is entering into the orbit, and you have seen this is the course of the nerve inside the orbit. So this orbit contains one gland, that is the lacrimal gland, in the superior part of the orbit, close to the anterior end and laterally. So superolateral, and in the close to the anterior part there is a fossa. This is known as lacrimal fossa, and that fossa contains this lacrimal gland. So the secretions are collected by lacrimal apparatus, and the sac lies within the orbit. This eyeball is kept in position by the sheath. This is the fascial sheath of the eyeball that works as the suspensory ligament of the eye, and this is thickened on either side, like this is the lateral check ligament, and on the medial side the medial check ligament. The gaps are filled up with the fat. So fat packed the orbital cavity. So the total orbital cavity is containing, there is no gap actually left inside the orbit. So let us go for a summary of the contents. One by one I will classify that content. So orbit contains eyeball and its covering sheath. There's extraocular muscles, 4 recti muscle and 2 oblique muscles. Nerves includes the optic nerve, oculomotor nerve, trochlear nerve, and 3 divisions of the ophthalmic division of trigeminal nerve. Vessels include the branches of the ophthalmic artery, tributaries of ophthalmic vein, and lymphatic vessels. Lacrimal glands and the lacrimal apparatus, means lacrimal sac is within the orbit, and the rest of the area is filled up with fat. So these are the contents of the eyeball. I tried to explain it gradually. What are the openings? Already we have seen it in the skull. So let me uh, explain the gross anatomy of this opening. The optic opening is there that leads into an optic canal that is close to the apex, and it is in the lesser wing of the sphenoid bone situated in the posterior part, and you can see this is traveled by the optic nerve, and within the optic nerve we get the central retinal artery. So optic nerve along with the central retinal artery passes through this optic canal. And the second thing, you can see this by the side of the optic canal, optic nerve, this through this optic canal passes the ophthalmic artery. So optic canal transmits the optic nerve with the central retinal artery, and by the side ophthalmic artery. The superior orbital fissure lies between the two wings of the sphenoid bone, and it's very important because a number of structure passes through this, and this is the position of the superior orbital fissure shown by the white dot line. You see, this is the diagram. This expresses the gross anatomy of the structure passing through the superior orbital fissure. One ring you can see that is formed by the tendon of fused 4 muscles of the extraocular muscles, and that includes, this ring includes the optic canal and part of the superior orbital fissure. So some structure passes through this. So let us explain the structure who passes the superior orbital fissure above the tendinous ring. These are the frontal nerve, this is the lacrimal nerve, and one of the branch, the nasociliary nerve, that passes through the tendon. These are the 3 divisions of the ophthalmic division of the trigeminal nerve. This is the trochlear nerve that passes above the ring, and within the ring passes this nasociliary nerve of the ophthalmic division of the trigeminal nerve. Oculomotor may pass as a separate division, and one cranial nerve is the abducent nerve. So all these 3, means abducent and oculomotor nerve as well as nasociliary branch of the ophthalmic division, passes through the ring, and you can see this is the ring formed by the muscles, and you can see the optic canal passing the optic nerve, and the small nerves, this yellow color, passing through the superior orbital fissure, and that part of the superior orbital fissure is behind the ring. This is the superior ophthalmic vein that passes through the upper part of the superior orbital fissure, and below the ring the infraorbital vein passes through the superior orbital fissure. So these are the structure passing through the superior orbital fissure, and also explained in relation to the tendinous ring. This is the inferior orbital fissure drawn a bit in a complex way, showing previously discussed all the foramens, means optic canal, supraorbital fissure. So here you can see this infraorbital fissure lies between the maxilla and the greater wing of the sphenoid. The total diagram is shown like this. The total fissure is shown the white, and this arrow is showing the infraorbital fissure. So this is the superior orbital fissure shown diagrammatically with the structure passing through it. This is the optic canal showing the structure passing through it, and this one is the tendinous ring who covers this optic canal as well as mid part of the superior orbital fissure. So the part diagrammatically drawn below is the infraorbital fissure. So let us see which the large nerve passing through it is the maxillary division of the trigeminal nerve. This enters into the orbit through the infraorbital fissure and enters into a canal in the floor. This is infraorbital canal present in the floor of the orbit, and in the face there is an opening of the infraorbital canal, and through that the infraorbital the nerve comes out in the form name of infraorbital nerve. So other structure includes the zygomatic nerve. This is the branch of the maxillary division of the trigeminal nerve. These are the vessels, inferior ophthalmic artery and inferior ophthalmic vein. Some emissary vein may pass through this opening too. Thank you very much for remaining with